Are you a person in your middle age that's been diagnosed with Parkinson's disease and you have no idea what caused it? You might even have the label that means they have no idea what caused it. That label is idiopathic Parkinson's disease. Idiopathic means the medical model has no idea what caused your Parkinson's disease, unknown cause, idiopathic. But the idiopathic label does not mean that there is not a cause to your Parkinson's disease. It just means conventional medicine hasn't found it for you. In today's case study, I want to show you a case of a 44-year-old male with idiopathic Parkinson's disease diagnosis for 4 years that when he came to work with me, we found multiple potential causes to his Parkinson's disease or potential issues that may be masquerading as Parkinson's disease, that if they weren't found, he'd never get help. But now that they've been found, they may change his life. Could that be you too? I'm Dr. John Bartemus, and I'm putting the pieces together to help you live a life at optimal. Before we dive in, please hit the subscription button and the notification bell so you can be notified when I post other case studies like this one. So as I said, we're working with a 44-year-old male with a diagnosis of idiopathic Parkinson's disease. Let's dive into that, okay? So, 44-year-old male, idiopathic Parkinson's disease, diagnosed in 2020. He began having a left-handed tremor in the fall of 2019. So he was diagnosed August of 2020, so it took about 6-10 months for him to get diagnosed. Okay, also interesting in the case that we will see is that he's also suspected to have ankylosing spondylitis, or AS for short. Okay, and also important for you to know is that this man was a carpenter and he's since been disabled since the Parkinson's diagnosis and hasn't been able to work since. All right, and so if we dive into this, you're going to see many factors that potentially are driving his disease process that medicine never tested for, doesn't consider, just labels him with the idiopathic Parkinson's disease, gives him his levodopa carbidopa at 125 dose 3 times a day, and on we go. The problem with that is that this man has been taking levodopa carbidopa, which is the gold standard treatment for Parkinson's disease, conventionally, by the way. He's been taking that for 4 years and he's no better. Okay, so a couple things there. A, if you're taking a medication for 4 years and you're no better, maybe there's some further investigation that needs to happen. And B, when you're taking a medication, there's no medication that doesn't have potential side effects. And as I talk about in my book, The Autoimmune Answer, in chapter 1, all about Parkinson's disease, I discuss how levodopa has the side effect of raising your homocysteine. Well, homocysteine is toxic to neurons, and so the drug given for the treatment for Parkinson's also promotes neuron toxicity. So it's like, what the heck? What are we accomplishing with that? Okay, and so we're going to see that matters in this case as well. So let's dive in, and there's so much that we found with labs that I don't even know where to start really, but I hope you take home that the standard labs they do for you are pathetic, and those labs were run on him and they call him normal. Meanwhile, we do more in-depth labs and look at all the stuff you're about to see. So the first thing we look at, and actually this was already tested on him because of the suspicion of ankylosing spondylitis, was genetic risk for inflammatory arthritic diseases. His medical doctor tested that, and that's a test called HLA-B27. So HLA-B27 is a gene that, if it's positive, increases your susceptibility to inflammatory arthritic diseases like ankylosing spondylitis, rheumatoid arthritis, etc. He was positive. Okay? So that would support or make us more interested in the ankylosing spondylitis, okay, and in that diagnosis for him. All right, while we're on the genetics side of things, I was interested in knowing what is his gluten sensitivity susceptibility. Does gluten bother him from a genetic standpoint? Okay, because as I talk about in my book, The Autoimmune Answer, in chapter 6, all on gluten, there is celiac disease of the gut, but there's also celiac disease of the skin and celiac disease of the brain, known as celiac brain. And so if this person has negative response to gluten and he continues to eat it as he has all the way up until he met me, then that could be gas on the fire of your neurodegenerative disease. So we looked at a gene, two genes. They're called HLA-DQ2 and HLA-DQ8. Well, he was positive for the DQ2 allele gene. So that is an increased susceptibility to celiac disease. That does not damn you to celiac disease, but having that positivity means you're more susceptible. Okay, so for example, if you, the viewer, are like him and you have a positive DQ2 allele and I have two negatives in DQ2 and DQ8, and you and I both drink beer until somebody develops celiac disease, your friends should bet on you winning or losing because you would develop celiac disease before me based on that genetic susceptibility. Okay, so again, doesn't damn you to it, but if you keep poking that bear, the likelihood that you develop it is higher in you than in me because you've got that genetic risk. All right, so he was positive for the genetic risk. Well, next to that, we also ran testing for celiac disease antibodies and gluten sensitivity in the form of gliadin antibodies and deaminated gluten peptide antibodies. Guess what? All positive, hugely positive, okay? So his tissue transglutaminase IgA and IgG antibodies were positive by over 2 times too high. Those are the antibodies that are positive if you've got a celiac disease process happening. His were 2 times too high. Massive response to gluten. He also had a positive gliadin antibody, okay? And that gliadin was IgG response. And he had a positive deaminated gluten peptide IgA response. Okay, so all of those, all the gluten testing, the celiac serology and the gluten sensitivity antibodies, all positive. Okay, so that makes me excited as the nerd that I am because I'm saying this guy, even if Parkinson's diagnosis is correct, he's got probably celiac brain going on too. He's at least got it in the gut. We didn't run the nuance between the different antibodies specific to brain, gut, or skin, but likely this is contributing to celiac brain and his neuroinflammation. And neuroinflammation, anything that's going to inflame the brain, is potentially going to exacerbate the Parkinson's disease. So that's huge. Well, guess what? In a study on 30 ankylosing spondylitis patients, looking at does gluten sensitivity impact ankylosing spondylitis, the paper found that 1/3 or 33% of ankylosing spondylitis patients, or AS patients, are gluten sensitive and have positivity to gliadin antibodies. Well, guess what? He did too, and they're suspecting AS in him. So is this a double whammy from gluten? Who knows? But guess what? If you cut out gluten, whatever contribution it's giving to those two things is eliminated. That's better than saying, hey, idiopathic, we don't know, take this drug, see you later, right? We can actually win and gain quality of life from this. So that's huge, just the gluten component. So let's move on from there. Next step, we talked about earlier, homocysteine. What was this man's homocysteine? You don't want to know. All right, his homocysteine was lab high at 17. That is massive. In my book, I talk about studies on Parkinson's disease that say researchers do not want your homocysteine higher than 11 if you have Parkinson's disease, because above 11 you're really blowing up neurons. Bam, 17. So he's blowing up neurons. And remember, levodopa promotes increased homocysteine. So the drug may be contributing to this number some. The drug isn't responsible for this whole number, I don't think, because of what I'm about to tell you. But 17 is massive. Any neuroinflammatory disease, you do not want to have high homocysteine. In multiple sclerosis research, Those scientists want your homocysteine less than 10, okay? Optimal is around 7. Homocysteine blows up neurons. It's also toxic to your heart and to your blood vessels. Most common symptom associated with it is brain fog or headache, but it can also drive anxiety, depression, and many other symptoms tied to a brain on fire. So we don't want this homocysteine high. Well, how do we lower it? All of us are making homocysteine right now, every moment of every day, because it's part of what's called the methylation cycle. Methylation cycle turns genes on and off, and when it's turning a gene on, it creates homocysteine, which can be recycled into methionine, which donates a methyl group to turn a gene on and off, and there we go, around and around in a circle. But if you're inefficient at recycling the homocysteine, it builds up and becomes toxic to various areas. How do we recycle it? If you're super into the health sphere and you've read blogs, you've probably heard of the MTHFR gene that codes for the methyl tetrahydrofolate reductase enzyme that is key in helping recycle this. You're on. Well, that enzyme requires vitamins to work, and the specific vitamin that enzyme needs is B9 or folate. Guess what his folate was? Lab low. His folate was lab low. Lab low folate, it was 4.4 nanograms per milliliter. Not good. If you don't have folate, you can't recycle homocysteine. It builds up, blows up neurons. All of a sudden your unexplainable Parkinson's disease is worse. Maybe it's not unexplainable. Maybe you don't run enough labs to explain anything. Okay? Also, his vitamin B6 was lab low at 1.6 nanograms per milliliter. That's terrible. Well, vitamin B6 is key at producing the brake pedal in the brain called GABA. If you don't have enough B6, you don't make GABA efficiently, and you lose that anti-anxiety effect of GABA. Well, guess what? GABA also plays a role in the basal ganglia, which is the part of the brain that's degenerating in Parkinson's disease. So if you're lacking GABA, that can contribute to the disease process. And his vitamin B2 and B3 were both borderline lab low. B2 and B3 are key for the production of nitric oxide synthase enzymes, which produce nitric oxide. Nitric oxide is one of the body's best vasodilators, okay, so allowing you to drive blood to the brain. Key to immunity, key to sexual function, key to vascular health, key to neuron health, so that your synapses can connect and propagate action potentials, and you can think and grab your coffee and whatever you're doing. So take home with him, B vitamins are in the trash. If you don't have enough B vitamins, you're in trouble, because B vitamins are part of our required cofactors for hundreds of enzymatic processes in the body, one of which is methylation, and in his case, driving up his homocysteine, blowing up neurons. Big problem right there. We need to get that number down, and we want it to be 7, okay? The research says for every 5-point drop in homocysteine, you get up to a 50% reduced risk of all-cause mortality. That means death from any causes. So bang for our buck, getting this down, or excuse me, bang for our clinical benefit, I should say, getting this down is a big move for him. And we don't need to move it just 5, we need to move it 10. So he could reduce his risk up to 100% by getting his homocysteine where we want it to be. Next, oh, one other thing I missed. His choline was also lab low. Choline is a nutrient that also is needed for methylation. It's a methyl donor, but as far as memory and cognitive function go, choline is needed to make our short-term memory neurotransmitter called acetylcholine. Choline's needed to make acetylcholine, and acetylcholine's also needed for vagus nerve function, okay? And all the things the vagus nerve does. And that could impact the gut-brain-brain-gut axis, which Parkinson's disease is a gut-brain axis disorder in many people. So getting his choline up is also going to be huge. Is he inflamed beyond what we see here? Yes, okay. Immune system-wise, his immune markers. That's interesting because his white blood cells are in optimal range. Okay, so the doctor would see that, give him a smiley face and move on. But there's more to your CBC than your white blood cell count. There's what's called the differential, looking at the different immune cells like neutrophils, lymphocytes, monocytes, etc. Well, his neutrophils were lab high and his lymphocytes were lab low. Okay? Neutrophils you could think of as first responders or Marines of your military. Lymphocytes are representative of your T cell subsets and kind of thought of as the first responders to viral stuff. So he could be more open to viral infection, and he's inflamed, neutrophils pumping out inflammation. Well, guess what? In the research, there's a marker called the neutrophil to lymphocyte ratio. Tons and tons and tons of papers on this and how it's related to risk of cardiovascular disease and cancer and all that stuff, okay? It's a simple math equation to do, and you want it to be less than 2 is the goal, okay? Guess what his was? 7.26. When it's greater than 2, that means you're chronically systemically inflamed. Hidden in plain sight, right on his CBC, which every doctor's office in the country runs, was this massive chronic systemic inflammatory marker. But no one had ever done the quick math to do it, to understand it. So he's wildly inflamed there. Is there other evidence that he's inflamed? Yes. His myeloperoxidase is lab high at 1,737 picomoles per liter. What is that? Myeloperoxidase is an inflammatory component created by neutrophils. Okay? And what it does is it blows up neurons in Parkinson's disease. It also is toxic to the vascular system. So again, heart disease risk, neuroinflammatory risk. It's related to pain risk and autoimmune risk as well. So we want to get this number down, and one way you do that is by balancing out the immune system so the neutrophils aren't so trigger happy. This promotes the neuron death by being toxic to mitochondria, which are the powerhouses of your cells. So big time number that we want to get down. The goal is to be below 400 there. The cardiovascular risk drops big time the lower you go below 470. So goal would be below 400 for him. All right, other pro-inflammatory findings. We tested his essential fatty acid levels. Why are essential fatty acids important? Well, because A, they're essential, which means unless we eat them, we don't get them, so you must consume them. And the omega-6 side of essential fatty acids are pro-inflammatory. The omega-3 side are anti-inflammatory. Omega-6s are everywhere in the American diet: cookies, crackers, chips, nuts, seeds, oils, breads, okay? And what do Americans eat? A lot of that stuff. And are Americans inflamed on average? Big time. Are they obese on average? Big time, okay? So too many omega-6s is not good. Remember, we need them. They're essential. Our bodies can't make them, so we must eat them, but we don't need to eat so much of them. The omega-3s are anti-inflammatory. You've heard of these as, say, fish oil or flaxseed or chia seeds, wild-caught fish, grass-fed meats, okay? So we tested his omega-6s and his omega-3s. The parent omega-6 is called arachidonic acid, or we'll call it AA. His arachidonic acid was lab high. The parent omega-3 is called EPA, eicosapentaenoic acid, and his was lab low. The reserve tank for EPA is called DPA, and that was also low. Okay, so he doesn't have enough of the anti-inflammatories. He has too much of the pro-inflammatory, and so that makes his pro-inflammatory to anti-inflammatory ratio too high at 74.4. All right, what you'd like that to be is 4:1 or less. So way too pro-inflammatory from an essential fatty acid standpoint. We got to raise his 3s, lower his 6s. Okay, that will change the inflammatory phenotype from an essential fatty acid standpoint. And now let's go to the gut. Okay, I said earlier, Parkinson's disease is often a gut-brain axis disease, or at least a contribution is there for it, and we see that in his case as well. You're only going to know if you run stool testing. Conventional medicine doesn't do that, okay? So they leave out what the research says is a huge component of this disease process and many others, okay? So in looking at his stool, we looked at, does he have enough probiotics? Does he have any bad bugs? What's going on in there, okay? So the first thing we see is that his probiotics are lacking. He is deficient in Faecalibacterium prausnitzii, which is a fun word to spell. And he's also deficient in 2 phyla, Bacteroides and Firmicutes. You could think of those like 2 big families of bugs that you need to have there. So lacking 2 families is a big deal. Faecalibacterium prausnitzii should make up 5% of the healthy human gut microbiome, which you're like, big deal, he's missing 5%. The gut microbiome should have trillions of good healthy bacteria in there. So if you're missing 5% of a trillion, that's a lot. If you wrote me a check for 5% of a trillion, I'd be very happy, right? So needs more of that. He's also on the low end of one called Rosaburia. And Rosaburia is important because they make short-chain fatty acids that help nourish the colon, nourish the gut, anti-inflammatory, etc. So he's not doing well with his probiotics, which if you're lacking the good guys, any bad guys or potential bad guys become more dangerous, okay? If you don't have enough police surveilling your streets, someone who wouldn't have been a bad guy if there were enough police may get a little brave if there's not enough police and start to misbehave, okay? So in looking at the potential misbehaviors, bad bugs potentially, okay, he had lab high, okay, so these were all low, okay? He had lab high Citrobacter species, and Citrobacter is a gram-negative bacterium that's associated with inflammatory bowel disease in rodent models, so Crohn's disease, ulcerative colitis, celiac disease, that sort of thing. So driving inflammation in the gut. He also had presence of Helicobacter pylori or H. pylori, and H. pylori likes to colonize the stomach and interfere with your protein digestion, causally associated with stomach cancer, stomach ulcers, acid reflux, interfere with B vitamin absorption. Like to see that not there if we can help it. Okay, so we see dysbiosis or imbalanced bugs. Is there any evidence on the stool that this is actually causing inflammation though? Good question. And the answer is yes. What we see, okay, from the combination of these 2 things is lab high eosinophil activation protein and lab high calprotectin. Well, eosinophil activation protein is produced by, you guessed it, immune cells called eosinophils. And it's very inflammatory. It's on the histamine side of things and basically will light up the gut environment. Calprotectin is the gold standard inflammatory marker in the GI. Okay? Research shows that you can use calprotectin to follow the progress of a case, and they use calprotectin to determine does a person have inflammatory bowel disease versus a not so inflammatory disease. And the line of demarcation for them thinking inflammatory bowel disease or not is 200 or more. Okay, so if you have a calprotectin above 200, they're thinking, hey, is there Crohn's disease, ulcerative colitis, celiac disease, that sort of thing going on? If it's below 200 but above 50, it's still lab high, but the inflammation is suspected to be something other than inflammatory bowel disease. So in his case, his calprotectin was 98, which is lab high, not quite at inflammatory bowel disease levels, but high. He is inflamed in the gut. Why? Partially from the dysbiosis we see, and maybe partially from consuming gluten and going down there and irritating that gut barrier and setting the immune system off. Lastly, one other key nutrient that this man was deficient in was vitamin D. His vitamin D was lab low at 18.8 nanograms per milliliter. That is awful. The lab low cutoff is 30. But health starts to be suboptimal if you're below 50, okay? Vitamin D is a key anti-inflammatory, immune balancer, good for bone health and muscle health, and in neurologic issues, D is key for dopamine signaling. Well, why would that be important in this case? Parkinson's disease, dopamine is a key issue, a lack of dopamine physiology, interference with dopamine physiology. Well, if we could have better dopamine signaling from optimal vitamin D, that might create a significant improvement for this man. So again, answers are there. You need to know how to look for them. And it's criminal that they don't run a vitamin D. Vitamin D is cheap and easy to test for. So I hope that you would agree with me that this person's case is not idiopathic. Remember way back 30 minutes ago, I said idiopathic means unexplainable. It's only unexplainable because they didn't look deep enough, I believe. Okay? He's got multiple things that independently could drive neuroinflammation and disease and symptoms that look like Parkinson's. Celiac brain from consuming gluten bombs all day, every day, with genetic susceptibility to it. Okay? Homocysteine that will blow up neurons whether you have a Parkinson's disease label or not. Systemic inflammation from immune imbalance and potential infections under there. Essential fatty acid imbalance, pro-inflammatory bias. Gut dysbiosis with serious inflammation in there. Through gut-brain, brain-gut loops, you can drive neuroinflammation from gut inflammation. And he's got a genetic predisposition to be more inflamed. So an idiopathic label, I think, is unnecessary here and kind of lazy, but that's how our healthcare system does it. We want to dig deeper and do the investigation to not call it idiopathic, give them a drug and never do anything different, especially a drug that raises a number that they didn't test, that their research shows blows up brains. Okay, so let's look at him, see what's actionable. All of this is actionable. So if we go after this and change these things and optimize these things, does he look like a completely different person? Can he get walking faster, speaking faster, less tremors? Could he possibly be not disabled and go back to work? As a 44-year-old, can he live the rest of his life at optimal? That's what we can find out. If you're out there with this label or another label for a chronic disease and they're not doing anything but putting you on a drug and sending you out the door and you want more for yourself and your family, reach out at functionalmedicinecharlotte.com.